All right, I think we're ready to get started. Thank you to the 93 people joining this morning for the Santis webinar, Preparing for the Next Wave. This is the second webinar we've hosted since COVID-19 was declared an international pandemic. The first was held in early April and focused on the steps that the federal and provincial governments were taking to deal with what was then a mounting public health emergency. We're now at a point more than 60 days after some provinces started to declare states of emergency that I think there's cautious optimism that the peak of infection growth rates have passed, that we generally have succeeded in flattening the curve and ensuring that our health system wasn't overwhelmed with people needing ventilators. And at this point, many policymakers are turning the collective attention towards three things. The first is really doing a deep inventory of the damage, the extensive damage that has been done over the past 60 days to our economy, to our health, not just our health system, but our health, and to our broader society. Second, looking at the steps that we can take to get ourselves back on our feet and address that damage. And third, and of course, incredibly important to our future, making sure that we have a very clear game plan in place to ensure that potential future waves of COVID can be managed with far, far less collateral damage to our overall health and well-being. My name is Dan Carbon. I'm a principal at Santis Health, and I'm joined today by my colleagues, Peter Cleary and Kelty Gale, who, if we switch to the next slide, you'd see the lovely pictures of. Collectively, on the next slide, we are representatives of Santis Health, which is a public affairs and strategic advisory firm that provides services exclusively to clients and organizations in the Canadian health and life sciences sector. The agenda today, we're going to provide a little bit of context in terms of where we find ourselves today in the arc of the response to COVID-19. We're going to then walk through what we see as the key impacts across the healthcare system, looking at the acute system, the community system, the primary care system, and a little bit of an impact on the innovation ecosystem. Peter is then going to talk about where we go from here in terms of next steps in government responses at the provincial and federal levels. We're then going to talk a little bit about try to summarize things in terms of the key takeaways and spend at least 15 minutes for your questions. So in terms of the context of where we find ourselves, when we last did a webinar at the beginning of April, Canada had at that point about 9,000 declared cases. If you shift to today, and you look at the map as of May 12th, we have almost 10 times as many cases of COVID that have been identified. Recognizing the limitations in testing, the actual number of cases is likely many multiples of that. Interestingly, as many of you know, the majority of cases in Canada to date appear to have been in Quebec, and combined central Canada, Ontario, and Quebec make up over 80% of the cases in Canada. So that's where Canada has been the hardest hit, with relatively less impact on the West Coast and in the prairies. If you put Canada in international context with some peers, obviously, we're doing far better than the United States at this stage. The U.S. has over twice as many cases per capita as Canada. One of the things that's really interesting, though, is if you look at the death rates and the impact of COVID, it's really different depending on the jurisdiction. In Canada, over 80% of those 5,000 deaths have thus far been in the long-term care sector. We've had just around 1,000 deaths in the broader community, a huge concentration in long-term care. In fact, more deaths per capita in long-term care than in the US, where only a third of those 80,000 plus deaths have been in the long-term care sector. So really in Canada, we're dealing with two very different situations of very well managed kind of outbreaks in the community with very, very low rates of death, so far lower in the community than what you'd expect to see in a flu season, but a very significant impact in long-term care and in other congregate settings. The federal government response to this crisis has, I think, largely been to accept that governments which mandated the shutdown have a huge responsibility to assist those that are impacted by the COVID response. And there's been an unprecedented and very, very rapid rollout of broad-based supports and relief measures that are targeted at individuals, communities, and businesses. And I'm not going to read through all of these new programs and policies. Many of you would be familiar with some of them. This deck will be available to people outside the webinar if you would like to see an inventory of all of the responses. I'd like to say this list is not exhaustive. There are new policy announcements literally every day by the provincial and federal governments with new supports that are rolled out targeted to individuals, communities, or businesses that will be falling through the cracks, and we can expect many more of these types of programs to roll out in the future. So if we skip through to this is just a list of the supports for businesses. The one area that the federal government has been relatively shy in providing direct support is involving itself in the health delivery system itself. This could be described as respecting provincial jurisdiction. A less charitable description might be that the federal government does not want to involve itself at all in the challenges that the provincial healthcare delivery systems will be facing, not just now, but in the aftermath of the initial peak of COVID. The one kind of area or way that the federal government has involved itself more directly in the delivery system, but aligned with the principle of providing income supports, is this funding for essential worker pay. But even this program has rolled out very clearly respecting provincial jurisdiction. The federal government has provided transfers to provinces who are able to largely design programs and target that funding to essential workers who meet the federal criteria. Federal government is providing between 2/3 and 3/4. It's not totally clear of the funding for this essential worker top-up pay, and we've included 6 examples here of very different approaches by provincial governments to meet what they see as the local needs. The NDP government in British Columbia has really topped things up, respecting the collective agreements in place, where Ontario, by contrast, has decided to provide a $4 top-up for a huge range of workers, ranging from relatively highly paid nurse practitioners in hospitals that would be making 6 figures right through to personal support workers in the community who might be making $16. So a very kind of a diversity of response there across the country. As mentioned earlier, the costs for the federal government of the response to the pandemic are unprecedented in the post-wartime period. The measures put in place to date of the direct response measures are almost 150 billion. 76 billion of that is related to the emergency wage subsidy, providing up to 75% of the wages for private sector business, where essentially the payrolls of a good chunk of the private sector economy have been nationalized and paid for by the federal government. The CERB is $35 billion. All told, the expectation is that our budget this year will be somewhere around $250 billion, although that number continues to deteriorate. The overall debt of Canada is expected to exceed $1 trillion relatively soon. And this has had a major impact on our debt to GDP ratio, which is the measure that Finance Minister Morneau has tried to kind of keep consistent, even as Canada has added debt in recent years. It'll grow from somewhere in the low 30s to just this year to almost 50% of GDP. I think it is worth keeping in mind that the debt to GDP ratio during World War II did grow to exceed 100%. So there is precedent for very rapid and even more significant debt growth in comparison to the overall economy. But the rate of growth at the moment has been quite eye-watering. We talked about this in the last webinar, and that there's a phenomenon where during times of emergency and crisis, the public rallies around leadership, generally irrespective of how competent that leadership is. And you saw this in the US with Donald Trump getting a massive boost in approval ratings early in the crisis. And in Canada, at the municipal, provincial, and federal level, you've seen significant boosts in popularity, notwithstanding the impact of COVID-19 on the local population. So the highest degree of popularity for Francois Legault in Quebec, which has been the hardest hit. This seems to cross party lines. You've got Conservatives and NDP leaders getting a significant bump in popularity. Do want to point out just two quick things on this before we move on in terms of what you take away from this. The first is that this bump in popularity is and approval is by no means durable. It is for the acute phase of the crisis. I think back to when George W. Bush was in power in the US in September 11th, and I remember him going from a relatively unpopular leader, kind of like Doug Ford pre-COVID, to suddenly having over 80% of popular support in terms of the immediate response to 9/11. That popularity withered away very, very quickly over a period of time related to the invasions of Afghanistan and Iraq, and Bush became one of the least popular presidents. So I think we can expect that these sky-high approval ratings will decrease. The second thing to note is that approval and popularity ratings are not necessarily tied to voting intention. So Justin Trudeau here is ranking lower in terms of approval during the response than Doug Ford is. But the federal Liberals have seen massive improvements in voting intention during the COVID response, which is leading some to speculate that there could be a fall election federally to try and secure a majority for the Liberal Party. Doug Ford, who by most measures has done very well during this response and seen his personal popularity skyrocket, has not seen his political fortunes really change that much. The Conservatives in Ontario are still running pretty neck and neck with the now third party Liberals. So it's worth keeping that in mind as we move forward. I'm now going to shift over to my colleague, Kelty Gale, who's going to walk us through the health sector situation report.
Thanks, Dan. Against all of that context, we want to talk about what the provinces have been doing, and particularly in different sectors of the health system. So overall, the provinces have been really focused on physical distancing measures and enforcing those measures, restricting the economy to essential services, which we're starting to see change now as they look at reopening. And they've agreed to federal common principles for reopening, but each province is still very much in charge and doing their own thing on how they will reopen. But overall, the primary focus has been on the health sector and on ensuring an adequate supply of PPE, support for frontline workers, COVID testing, contact tracing, and trying to make sure that we can contain this pandemic from a health sector focus. When we had the last webinar, we were still in a phase where the anticipated response to the pandemic was that hospitals would really be at the center of this and would be the hardest hit, and they were really preparing for that. And we've seen since then that long-term care, as Dan said, has really been the center of the outbreaks in Canada, with over 80% of the deaths across Canada being residents of long-term care. And you've seen that Ontario and Quebec have both called in the Canadian Armed Forces personnel to be deployed to help in homes. These are really the largest and most severe outbreaks. The federal government is now looking at creating a training program for unemployed Canadians to provide assistance in long-term care. They're looking at some sort of shortened version of a training so that people will be able to perform the less complicated tasks required in a home to really manage some of the staffing issues. One of the interesting things looking forward from this is that this crisis will have a lasting and ongoing impact on some of the structural issues in long-term care. Some of these are the physical issues, so things like multi-bed wards where you've got 4 residents in one room with curtains separating them, shared washrooms and bathing areas, narrow hallways. Those are really challenging structures when it comes to an infection control perspective. And so long-term care sector has been calling for a long time for support to move beyond those kind of physical structures. And I think we're finally seeing attention on that. I think there will be new ways of managing infection control and a whole new perspective on what that needs to look like. New staffing models. You've seen many provinces, if not all of them, restrict movement of PSWs between long-term care homes, that they will only work in one home. But I think what that really highlighted is that PSWs were working in more than one home because they did not have full-time employment from one long-term care home. And then finally, the federal government has been called on to regulate and provide funding for long-term care, which would be a new jurisdiction for them. They could tie it to a health accord and provide that funding as well as some standards, but they could also look at moving into new legislation and setting standards and regulations across the country. The home and community care sector has really been called on throughout this to help alleviate the pressure on hospitals, particularly when that was looking like it would be the nexus of this pandemic. And in Ontario, for example, when they did their fiscal update, they announced $124 million for 90 transitional care projects to help move people out of hospital who didn't need to be there as quickly as possible. Thinking that hospitals would need that capacity, particularly in their ICUs. The challenge for home care companies through this, in part, is seeing lower volumes as residents worry about people coming into their homes. And they've really had some challenges with PPE supply and making sure that workers will be adequately protected. All in the home care sector, similar to long-term care, they've had challenges with staffing of individual PSWs working in many locations, different congregate care settings being served by many companies. And so you've got lots of people in and out of these buildings. And then again, the issues of part-time work and pay issues highlighted by this crisis. You've got the federal government now stepping in along with provinces to provide pay top-ups. I think you're really starting to see, particularly in the media and the public conversation, some of these issues that have existed for a long time come to light. One of the interesting things in this sector is that the impact of virtual care and other remote technologies is still not really fully understood and known. There are definitely some amazing, interesting technologies that can make a big difference to how the sector operates, but it's also very difficult to replace some of the work, and impossible to replace some of the work that a PSW doing things like helping someone get out of bed, get dressed, shower. Those things will not ever be able to be replaced by technology, at least in the sort of foreseeable future. As I said, hospitals were really where all the focus was at the beginning. So they were really quick to pivot their operations to focus exclusively on COVID-19. That focus was very much about creating capacity, especially in ICUs, associated staffing changes with how you manage a hospital that has much more ICU capacity, managing PPE. That was the big topic, especially at the beginning of this, when there were significant shortages and managing those supply chains, equipment capacity, especially ventilators and drug supply to put people on ventilators, and then deferring elective surgeries. And one of the things looking forward now, as we start looking at opening up the healthcare system, is this shifting focus to the major backlog of elective surgeries. And BC has said that at the beginning of this, in early March, they already had 93,000 people waiting for elective surgery. They have, over the course of the last 2 months, had 30,000 postponed surgeries, and are now saying that it's likely going to take 17 to 24 months to work through that backlog and keep up with the new demands. And that is 17 to 24 months, even though they're looking at hiring, expanding OR hours, looking at private clinics to take on more surgeries, and putting $250 million into the health budget to deal with the surgical backlog. And it could still take up to 2 years. So this is going to be an ongoing challenge to manage that backlog of elective surgeries. At the same time, hospitals will need to focus on maintaining capacity for COVID-19 cases, especially as there is likely to be some sort of resurgence as as the economy reopens and people leave their homes again. Ontario has proposed the idea of designated COVID-19 hospitals. So you would have certain hospitals that were focused entirely on other things, but we would maintain capacity with these designated hospitals. The final thing here is that throughout this crisis, the hospitals have seen people coming to the emergency department much later than usual. People are avoiding the hospital at all costs if they can. And so there's been many stories of people arriving in hospital with heart attacks that are pretty progressed, and that usually you would have seen those people way sooner, or other challenges as well. People are just arriving in the emergency department much sicker than they usually are. So I think that will also be a more of a short-term challenge to shift people's thinking into going to hospital again when they need to. The mental health and addiction sector has been responding to this crisis already, but also is really likely to see a huge ramp up as we move through this pandemic. According to a CMHA Ontario poll that came out this week, the 7 out of 10 Ontarians believe the province is headed for a serious mental health crisis as it emerges from the pandemic. More than half of people believe that their mental health or those in their household, their friends and family, have been negatively affected by the pandemic. And a quarter of Ontarians are consuming more substances, such as alcohol, tobacco, and cannabis throughout this. What all of that points to is that we are headed towards a major influx of mental health need in our system, which was already there and already not necessarily adequately managed. And so the government has started responding to this already. There's been a broad federal and provincial response with funding primarily for online mental health platforms and virtual care, mostly in ICBT and aimed at those with mild to moderate depression and anxiety. One of the challenges with that is that then you also need to somehow manage in a system those folks who are not in the mild to moderate category, and to be triaging people and actually providing adequate care across an entire spectrum of need. The government has also had targeted funding for particular areas. So kids, especially through Kids Help Phone, people suffering from domestic violence, and frontline workers. Frontline workers have really come to the top of this list as people who are going to have mental health challenges coming out of this, and that we really need to be prepared as a system to deal with that. The main response from primary care throughout this pandemic has been to look at virtual care solutions and to try and continue serving patients through these virtual solutions. But it's a bit of a wild west. There has been no standardization. So you've got people using government-approved platforms. You've got people using non-approved platforms like Zoom. The phone counts as a virtual care solution in lots of cases, and people using things that are built into their EMR system. So there's not a lot of standards, and there's not a lot of consistency across the virtual care solutions that are being implemented. There's been very little communication to primary care providers about what they should be doing. And because there has virtual care is suddenly being used so much more, it's really being left to individual decision about what can be treated virtually, with not a lot of clinical protocols or clinical guidelines for how to manage this. So moving forward, I think that will be one of the areas, if we are to maintain the virtual care capacity, which for those of you in Ontario, you'll know that the Ontario government has been very keen on ramping up virtual care capacity. But if we are to maintain that, we'll need things like those new clinical protocols for how to manage this, and we'll need a fee code adjustment to ensure parity. To maintain those volumes, physicians can't be financially penalized for virtual visits when they are clinically appropriate. And so we'll need to make sure that the schedule of benefits and the fee code will actually benefit all primary care providers and allow them to continue using virtual care. PPE will also be a concern in this area, as it is in others, but for physicians, for primary care providers trying to reopen their offices, we'll need to make sure that there is also an adequate supply of PPE and that they are included in the groups we're thinking about in terms of supplying the necessary protection. Public health has been at the front lines of this, but as an entire system, when you look across all of public health, they were really not prepared for a pandemic. Decision-making in the public health space is really dispersed and at times unclear between the local level, provincial, federal, and there's been some tension around who is making decisions. There are very different standards, processes, and protocols between health units. They're working with old technologies. There are still places who are relying on fax machine as their primary mode of communication between other areas. And it's not that public health professionals didn't know these issues existed. They've been raising them many times, but the changes hadn't been made. There wasn't really political will to buy into what is essentially an expensive insurance policy in case we headed towards a pandemic. And now we've seen the impact that has when you don't invest when you can in advance of these things. I think we're starting to see already, and I think we will see even more tension between public health professionals and politicians. And you've seen some of that this week in Ontario with Doug Ford saying, we're ready to open up, we're going to announce phase 1, and David Williams saying, we're actually not there yet. The data doesn't support it. And that tension between what the health data is showing us and what the economic data is showing us as a real challenge for people, I think will become more and more of a tension between public health and politicians. We are also already seeing that these challenges are likely to lead to an evaluation and restructuring of public health following the pandemic. Doug Ford has already hinted at restructuring so that some more of the jurisdiction is with the province rather than with local health units. Overall, public health has been historically underfunded, underappreciated, and underprepared until they were needed. And it's still to be seen whether this pandemic will be the wake-up call and whether as an entire health system we will invest differently in public health going forward. And then finally, in the pharma and medtech sector, there's a lot of activity, particularly for pharma companies around vaccine development and managing drug supply. On the vaccine development front, we are really working as a global society towards trying to find this vaccine in record time. The average is somewhere around 13 years, and we're aiming for 1 year. With what the World Health Organization has called a moonshot at trying to find a vaccine that quickly. At the same time, there's big emphasis on managing drug supply and ensuring that people who do end up in hospital will have the drugs they need, especially the drugs that are needed to put someone on a ventilator. MedTech companies are focused on essential equipment in a lot of cases, and then on launching new virtual care platforms as there's this huge expansion in virtual care. From a regulatory perspective, Health Canada has been really focused also on managing drug shortages and then on rapid approval for tests and treatment. Just this week, they've authorized the first serological antibody test to be used in labs and to understand better whether people who are infected with the virus are then immune. But they've really been focused on this rapid approval. CADTH and its counterpart in Quebec, INES, are focused on compiling evidence about COVID-19 and have been putting out briefs frequently, including a report from CADTH just recently about non-essential surgeries and moving that forward and how we reopen that part of our health system. The Patent and Medicine Prices Review Board, PMPRB, has said they are making significant changes to their draft guidelines, and now we're anticipating an implementation delay. That it was supposed to be July, and now it's looking like it will be next January. on how when PMPRB implements those guidelines. And then the Pan-Canadian Pharmaceutical Alliance is reprioritizing their negotiations to focus on drugs with a net new benefit and drugs that will offer cost savings to provinces whose budgets are really strapped and that will be even more tight coming out of this than they were before. And then finally, the federal government and other advocates will have a strengthened argument here for national pharmacare, as millions of Canadians have lost their jobs and lost their drug coverage. The numbers are even stronger to show why that safety net, for those who think that's the way to go, they've now got stronger data to back that up. And you've seen Eric Hoskins come out and talk about that several times throughout this, of that is now an area where the federal government can keep moving forward. I think they're very focused on COVID for now, but I think we can expect that to come back up as an important policy measure that they're looking at. And with that, I'm going to pass it over to Peter to talk about where we are headed next and what all of this might mean moving forward.
Thanks, Kelty. Not a small task, given everything that you just went over. And so before I start, thanks everybody for using the Q&A function. I've been trying to type as we go for some of them. We're gonna save some of the questions to the end that we don't necessarily answer in the presentation. There's also the chat function as well too. If people have answers themselves that they wish to share, I like people using that chat function. It's great to see. And then I also posted that we will be sharing this presentation around afterwards. And we're also going to be circulating a bit of a survey so we can get a better handle on how we can shape these for the future. So given all of that, where do we go from here? And this is not an exhaustive list. I actually, this slide took a matter of seconds to create because if we're thinking about what we actually need to deal with another wave, whether the wave is less significant or more significant in any way, there was one question that came in terms of where is public health on contact tracing, and more to the point, I think, community surveillance. The reality is they're not there yet. If one of our principles is that we need to have that in place to fully reopen or even reopen at 50 or 60%, we're probably not where we need to be. Our last webinar, we put up some graphics to show where Canada's ICU bed count per capita compared to other countries sits, and we don't have a lot of ICU beds, and frankly, our beds are usually full, and we're going to have to figure out how to manage that, as well as get medical devices into Canada that we might not necessarily produce right now. Government's clearly focused on that. Drug shortages is going to continue to ramp up, especially as distribution and supply challenges become more acute. Kelty spoke to a couple of these things already, and there's a couple questions on virtual care that we can get to at the end, and I think Dan has been going through and answering, as well as the fact that we just frankly need to modernize our public health system, and our infrastructure is not where it needs to be to care for Canadians in a number of different settings. So this is a lot for any government to deal with in a decade, let alone to deal with in 6 months. So our challenge collectively, and government's challenge, is not a small one that they will have to tackle. So right now, they were really focused on hospitals. I don't need to repeat too much of what Kelty said, but the government handled the capacity challenge by closing up the healthcare system in some respect. And in order to prevent a larger health crisis from emerging, they will need to keep the health system open, deal with elective surgeries before they become essential surgeries, and they need to make sure that we are no longer shut down, because frankly, if this is going to last as long as it is, we need to figure out how we can operate at a significant capacity so that we are not leaving some people behind. And I think in the early days of this crisis, government truly was reacting to louder groups. And that's not a slight against those who were able to punch through the noise. In fact, that's a very helpful and successful tactic. But as the longer this goes on, the more people that will be impacted, and the more we will need to figure out how we operate in that new normal as these waves come and go. So how will we learn from all of this? We can look to a couple examples of what sort of reviews were done in the past, and we're starting to see this discourse enter into the thinking of civil society and governments. You have the Campbell Commission that came out after SARS. It took many years to complete. It was a massive report, and old names are new again. So, you know, specifically David Naylor, who's still hopping around, as everybody has seen. There's the National Advisory Committee on SARS that was a Health Canada-driven report, which led to the creation of PHAC. Both of these, you could argue, not all the recommendations were implemented. You could probably go further, especially on the Ontario Campbell Commission, and say only a small minority of them were implemented. But you know, we kind of have the structure of what was done in the past. So what could we see happen now? And I would say on the reviews, there will be politics starting to play into this as well. So at the provincial level, you're going to see, and you already are seeing, provincial opposition parties call for full-on inquiries and commissions. And there are some governments that will grab a hold of that and own it, and there will be some that probably get dragged into it, but that's probably where they're going to have to end up no matter what. There will be a federal review of some point. I would suspect it's not going to be a Health Canada review like it was last time. And it's not there yet, but I think you'll start seeing the words Royal Commission bantered around as you get closer to the next federal election. Again, these things are usually politically motivated. There will be third-party initiated audits. So there's a lot of stakeholders, many of which are probably on this call, that are thinking, well, how can I provide input, not necessarily directly to these, but how can I in parallel put some information and data and shape the discussion about what has happened, and how do we deal with this in the meantime. There'll be a desire from the feds and others to get early learnings, so not having to wait 5 years. I would imagine a select committee and a minority parliament would probably want to dig into that, and I know many people on this call have had to present to committee once, if not twice, in the past couple of weeks, because committees are quite active and they want to hear from people. And I think they'll want to continue to hear from people. And there'll of course be a global response, who is under the thumb at the same time. So they will be investigated and investigating all at once. And I should say that all of these will be looked at in the lens of how do we do a review while also responding to the pandemic at the same time. And the Campbell Commission terms of reference specifically speaks to that they want the review to move forward without hindering any efforts to respond to the crisis. And I think you're starting to see that conversation be broached by those that wish to see reviews and audits and investigations begin sooner than later. But what will they focus on? Well, compared to SARS, COVID-19 is impacting nearly every jurisdiction and region of Canada, which was not necessarily the case with SARS. So I think there'll be a stronger case for national leadership when it comes to a report and review. And I think things will be broader just by the mere fact of the scope of the challenge. They'll need to distinguish between the public health system's structural issues and those who are working and operating within it to the best of their abilities. And any review will probably make it clear that this is not a reflection on those people who are trying their best, quite frankly, with what they have to work with. And at the same time, those systematic issues will also be put up against and separated from decisions made in real time. And this includes politicians and public health leaders that are making decisions based on the information they have in that moment. And you can see that less so now, but especially 2 months ago, 2 or 3 days felt like an eternity in terms of how this pandemic changed our way of life as more information was made available to us. Also uniquely different is the massive impact on the economy that Canada and the world hasn't seen since World War II or even before. It's significant, and it will play into all of this, if only because there are broader societal impacts. Things that we are thinking about and starting to talk about a little bit But there are reports about the increase in domestic violence incidents, the impact on mental health. Kelty spoke to this a little bit. And one that we haven't really talked about a lot, but especially with seniors over the past couple of years, there's been a conversation around the impact of just being socially isolated and what that was like for people in everyday life before this pandemic, let alone how that isolation is impacting them now. So how will this also impact what the feds have committed to doing and what the Prime Minister kind of indicated in his press conference, I think last week? I can't remember the exact day because time no longer has any meaning. But we know that the feds have strong commitments to pharmacare, to drug reform. There will likely be a question of, can they continue doing this with a fiscal situation, or for a government that believes in it so much, will they look at it and say, well, we have no choice to, there's even more reason to do it. Anticipate that conversation to really ramp up, and sector stakeholders to want to have that conversation, no matter where you fall on that. I think the greatest challenge is that the closing the gaps argument, you're no longer talking about a small number, but we'll have to see how many people go back to work and get access to private insurance. So watch those numbers closely, as they'll probably tell a story over time. And I think it's too soon to see what those numbers will show and prove for government. But there's a couple other things the Fed is committed to, which will be interesting to see how they review it in light of COVID. So the health accord on mental health and home and community care, and I know there were a couple questions on this. You may not know, it was a 10-year accord, but it was up for renegotiation after 5 years. So that's 2021, 22, that's up for renegotiation. There's a number of things that will likely be at the top of people's minds when they have that conversation. So one of the questions was around mental health. Are folks doing enough? Are they investing enough? Well, I would imagine that provinces will be going after the feds in 2021, 22, saying that we need more money, that our transfers were already decreased from 6% down to 3%. You're giving us targeted funding for mental health, and we have a crisis on our hands. Similarly, for home and community care, I would argue the last time, and I was there, so I can speak clearly, and I think Dan and I had this reflection in terms of the last 10, 15 years of governments. Long-term care, frankly, hasn't been a strong enough focus for many governments, and the home and community care health accord, I don't want to say it left out long-term care, but it definitely wasn't the focus, and long-term care infrastructure definitely wasn't in that either. So how the feds deal with that, whether it's through health accord negotiation or whether it's through Minister McKenna's infrastructure fund, it will be a big topic of discussion, let alone that the facts that the feds have already committed to reviewing and reforming the Canada Health Act. And I think when they made that commitment, it was probably smaller or lower in scope. And the Prime Minister has made comments to this again in his daily press conferences, which will raise a couple eyebrows and make people think that, well, how can they use that? I think we can have a really good Canada Health Act debate in terms of how useful, helpful, and enforceable it is. And we could probably save that for another day, or we should probably do a podcast on it, because I think people assume that the Canada Health Act can do more than it actually can, or what its capabilities are. And I think that's going to be one that healthcare nerds like myself will enjoy debating and influencing policy on. There are a bunch of other issues that they commit to doing that will inevitably have to come up, or they'll decide not to do anything on it at all. So vaping, marketing to kids, front of package labeling, and then opioid misuse is something that has been quiet, but I'm starting to see it poke its head back up, because the reality is people are still dying of overdoses, and it's just being eclipsed by COVID-19. There's a number of national strategies that I think will get back in action once the feds are able to figure out how to operate and get to work. So rare drugs, palliative care, concussions. I know there are others that it's silent from the feds right now. And I think that's just respective of the fact that people are responding to a crisis and they're figuring out how to operate as a department working from home. The PM said that they'll review all of these after they get out of the moment's crisis, but that he also said that there's been a number of things that have that we have seen highlighted as a result of COVID. And Again, not a complete list, but obviously public health modernization, infection control, mental health, again, that's a reoccurring one in this presentation. But two lenses that I think the government will probably put on all of this is the gender imbalances, the fact that women are being hit harder by the economic downturn than men, as well as the low and middle income Canadians really being hit by this pandemic as well. So what's the government going to be focusing on? So one, reopening the economy. So Kelty and Dan gave some high level comments to that. The reality is the workplaces, they'll never be the same. But we as the health community and us as people who like to work and influence and develop public policy, we need the economy to open so that the government can get back to work as well too. Everybody knows how hard it is to work with the federal bureaucracy when they're at home. This is a department or a government that operates predominantly on paper and dockets. They don't really have great online systems, to be honest. So my fear is that the longer this goes on, the less work will get done, say, on those national strategies that the feds even want to do. So it's also in government's interest to figure out how to reopen the economy so that they can get their workforce working at a higher capacity. And this is not a reflection saying that they're not, they're focused on a crisis, but it's a systematic issue of a federal government that operates on paper. There will be I think sooner than later, I think we'll be feverishly writing economic stimulus submissions and pre-budget submissions. You saw the PM was asked about that yesterday. There are budgets that are no longer, I mean, they're probably so old, say Alberta. I mean, it's not old from a time frame standpoint, but from a context standpoint, their budget they tabled before COVID and before the oil drop is probably meaningless now. And that there's others like Ontario and Ottawa that have not put their budget out. So you have standard processes that will start kicking in. I think MPs are sitting at home itching for stuff to do, which is why they're doing a lot of conference video calls right now. But I think you're going to start seeing conversations from MPs at committees or MLAs or MPPs in terms of what we should be investing in. And I think there'll be calls for those sorts of submissions sooner than later. And it will be interesting to see how the feds proceed with their budget process, whether it's ad hoc or at their normal time, but they will have to build in some sort of conversation with stakeholders, especially as they're looking for medium-term stimulus to influence and help the economy. And I'm going to wrap up. This is my last slide, and then I think I'm turning it over to Dan so we can answer questions. So government really is focused on economic stimulus, health system capacity, and the COVID-19 reviews will start coming into play. They'll be reviewing and adjusting and establishing new and priorities and looking at their old ones. So you will need to focus on how are you going to communicate your priorities through this lens of what government is focused on. You're going to have to figure out and think about how you can align your priorities with these government priorities, and the fact that this is an opportunity to influence existing objectives or help identify new objectives all through this lens. And now is the time for you to be thinking about that because it will be on you to directly start influencing them at the provincial and federal level a lot sooner than you think. So with that, I'm going to send it back to Dan to close this off.
Sure. And I think Peter talked about the Campbell Commission and the response to SARS. Obviously, we're dealing with something fundamentally different today. I was in government in the aftermath of SARS. The SARS response was one of I'd say the top 20 priorities that we were dealing with at the time, along with the kind of backlog in elective surgeries, the fact that something like 1.5 million people in Ontario couldn't get access to a family physician or care provider at the time. There's certainly a lot of focus put on investing in public health, investing in the capacity of the public health system, creating the public health agency in Ontario. But I think it's worth keeping in mind that SARS, while tragic for those who died, was really a blip from a societal perspective. There was no massive economic contraction. There was no huge change in society. As a population, we really moved on from SARS, and the PPE stockpiles that were invested in the aftermath of SARS, when those expired, and we've seen a number of stories about this recently, they weren't replenished. Someone told me a story last year that they were doing a humanitarian mission to Guatemala, and they were taking a bunch of N95 respirators with them that had been built up as part of the SARS response stockpile, and they'd all expired. So we were giving them away. That stockpile was not replenished. The lessons of SARS while they were very important and the Campbell Commission did great work, they didn't stick with us as a society. And I think our expectation, all of our expectations, is with the impact of COVID-19, there are going to be more fundamental changes that will impact our health system and our society, and that this response will play out not just in the weeks ahead, not just in the months ahead, but in the years ahead, and it will really shape how we interact with the health system and broader society differently. And with that, I'll leave these kind of key takeaways up. I won't go through them, but we'll turn our attention now to some of the Q&As that are up, and some that have not been addressed. As Peter said, we've been addressing many of them as we've been going through. Peter, I don't know if you can comment on how public health units are doing with contact tracing efforts. It's something I know a little bit about and can speak to if you don't want to address that, or Peter or Kelty.
Well, I'll just quickly say local public health units, and this is, again, when we were talking about, we have to be careful on how we judge the jobs people have been doing, because they have to do it within the resources that they have. And the resources that local public health units have had is fax machines. So the process has been, when a positive case goes through, they've been faxing that information over to public health units, and then public health units have to have their own individual processes in place in order to track down and contact individuals. And prior to COVID breaking out in Ottawa, for instance, I think they only had like 5 nurses or something, and please don't hold me to this number, but it was a low number of public health nurses that were focusing on this, and obviously the need is significantly more, so they had to add on to that. So that is to say that they've had to modernize very quickly. A lot of public health units are working on how to digitalize and create apps in order to help on this. I know that that's a large conversation across the country. The privacy commissioners from a pan-Canadian level put out a statement a couple of days ago in terms of how governments can and should and need to respect public health data as we start collecting more and moving away from fax machines and start tracking in the modern era. But the reality is, no, they're probably not there, and it's probably not their fault because they didn't have the resources to get it to where it was. And even though you had a lot of public health experts saying the pandemic is coming, it wasn't real enough to get the attention of government.
I'll just note on that I know Ontario a little better, and that there's a provincial government target for how many contacts can be traced someone that tests positive for COVID within a 24-hour period. Some of the public health units are reporting that they're already there. Of course, it's much easier to do that in an era where most people are kind of locked in their homes for the week and make one trip out to the grocery store. You're simply not coming in contact with that many people. The question on these human-based contact tracing models is what happens if the economy and the broader society turns back on, if people are traveling in public transit, if they're going into food courts and things like that. Contact tracing becomes much more difficult. As Peter mentioned, there's going to need to be capacity increases, both kind of in the human aspect of it and probably also in the technological aspect. There's lots of discussion about where this should be done and who has responsibility for it. Some public health units taking their own approaches, some provinces taking their own approaches, and then I think you saw in Ontario, Premier Ford 2 weeks ago suggesting that the federal government should develop a coherent kind of national strategy for contact tracing. There's a quick question, Peter, that I think you can knock off. What changes are expected to PMPRB guidelines?
Yeah, I think this is one that's been out in the ether for a little while. I think they'll probably be delaying the actual implementation date because of COVID. There were guidelines that they haven't actually released and got consultation or undertaken a consultation on. So I would suspect it's a combination of PMPRB needing more time and in response to stakeholders needing more time as a result of COVID, work from home, and not being able to appropriately develop the guidelines that need to be developed in order for the coming into force date to start July 1st. But you said changes. Sorry, I'm looking at that, Manny. I don't know. The PMPRB hasn't said the changes. They put out a statement a while ago saying that they're going to do significant changes, but they haven't yet said what those are. So we are anxiously, along with many others, waiting for those new guidelines to come out, and we have no idea when those guidelines will be put out for consultation.
There's a question here around provinces outlining their plans and timelines to reopen long-term care to families and visitors. Kelty, I don't know if you have any information on that.
I haven't seen anything specific that actually tells us a timeline. I think the best guess is that it will be dependent on the home and what the situation in different homes are. I think what we can expect is that there will be a very different structure of visiting and what infection control around visitors and looks like in long-term care going forward. I have not seen dates associated with any of this, though BC has said soon.
There's one question regarding commitment to kind of government pre-COVID transformation agendas, and in particular in Ontario related to Ontario health teams and the kind of care integration. I'll try and address that. I spoke to someone in government last week, and they said they're going through a process right now, and it's a somewhat organic and evolving process of trying to understand what of those pre-COVID priorities remain government priorities and how much attention is given to them. Obviously, they're going to have to balance the pre-pandemic agenda with both the measures that they need to take, continue to take to prevent an upswing in infection, and then all of the ancillary kind of collateral damages and impacts associated with the pandemic response. And then also the policy response that's necessary to address the kind of frailties of the system as we've seen from the pandemic response. So in Ontario, they're going to have as new priorities, a restructuring of the public health system and how the local public health units and Public Health Ontario and the provincial government work together and kind of who calls the shots, how are decisions made, and a significant focus on restructuring of long-term care to better prepare it for future waves of infection. So it's unclear how previous priorities like Ontario health teams, how much emphasis is given to them going forward. Although, of course, integration of care between long-term care, the community, primary care, and hospitals, you would think would be ever more important in the future. There's a question around other health human resources from Glenn Brimacombe. In a world of not enough family docs and psychiatrists, is there an untapped role for psychology to be better integrated into the public health system? And Peter, I don't know if you want to speak to just health human resources in general and the impact of that and shifting kind of who does what in healthcare and whether there'll be a systematic look at that.
There's a couple questions on HHR, and we could probably have a whole conversation based on that. So there needs to be a conversation, it started at the stakeholder level over the past year or two. And I will just say, and with respect to many people are representing health professional organizations here, coming from a minister's office background, oftentimes you sit back and watch a scope of practice fight take place between a lot of professions. And that will always be a bit of a challenge because when you're representing a specific organization or scope or profession, you want to protect your ground and expand that where possible, which totally makes sense. So when you're sitting in a position of authority managing that, it can be a particularly challenging thing to do, and especially as we move on from a pandemic, there will need to be some sort of reflection to try and disentangle the competing priorities of stakeholders with what the overall objective of the system will be. That will be a very tough conversation for government to lead. And I think this is where the political will comes in for these sorts of changes, because I think there's going to be a lot of angry people or challenging conversations with the health sector broadly to try and move that forward. I'm not a huge expert on this. My colleague Ian Chesney worked on it a lot more. But I would just provide that overall comment that it's not an easy position for government to be in, because inevitably the only winners should be patients at the end of the day, but there will be there will probably end up being some unhappy stakeholders if we do a strong process of HHR reorg coming out of the crisis at the provincial level. I hope that's a fair comment to say rather. I don't know. another question here that I just see that I might as well hit off. It's in the Zoom chat. Oops, I don't mean to change the John Christensen on the chat. You asked a couple of questions there, and the one that caught my attention, which I thought was interesting, you said, why do you think the federal government misled Canadians by initially saying face masks are not effective at preventing COVID-19? I take issue with saying that they misled. I don't think they misled. I think that's a challenging conversation to have, because I think probably the federal government could have been a lot better in educating and explaining to Canadians how to properly use face masks, because oftentimes they're just used badly. Even when I go to Costco, I see people in the store with a face mask, and as they walk out of the store, they pull the face mask down with their hand and just leave it sitting on their chin. So that means the exterior of the face mask and the interior are just mixing all over their face anyway. So I think this is more a conversation about how do you properly use face masks. And I think what I would suspect the government was saying was, if they're not used properly, it's not going to help. And I think they probably erred in the response by first saying, well, let's have a conversation how to properly use face masks, because many countries around the world are recommending that they use them. So I think that's an interesting question, frankly. And I guess, Dan, it's 11 o'clock. We'll have to decide how long we keep going. There's lots of questions here.
Yeah, is there a way, Peter, for us to respond to some of the questions in writing after the webinar has been closed?
Yeah, we totally can.
So we can do that for people who have asked questions that we have not yet answered. I'm conscious that many people have been dropping off for other meetings. Peter, the other question that we've received a lot is, how do people get access to the presentation and the slides? Can you just kind of comment on that, and then we'll wrap up?
Our great team at Santis will be circulating it in an email, if not today, tomorrow. But we will send a copy of this presentation out, as well as recording.
Thank you very much for all of those who've joined us today. As much as we would like that there not to be a third COVID-related webinar, if we're still in the thick of this within a few months, we will endeavor to provide an update at that time, highlighting what has changed. Thank you very much.